Good afternoon, everyone. Welcome to today's webinar session. I hope you can hear me clearly. So we have an interesting topic. We've been looking at pain management with NSAIDS. My name is Dr. Esther Nafula. I'm a palliative care physician and I head the pain and palliative care unit. Last week, we looked at what NSAIDS are, how to classify NSAIDS, and we looked a bit about some considerations for patients with renal disease. And this week, we want to continue the discussion by just talking more about NSAIDS. So we are privileged to have Dr. Nyambura Kariuki with us. She's a consultant pediatrician, a hemato-oncologist currently practicing at KNH, also at Nairobi Hospital, Mpisha and Gertrude's Children's Hospital. She's a senior lecturer at the Faculty of Medicine, University of Nairobi. She works a lot with undergraduate and residency training programs in the School of Medicine. And she's very active in trainings concerning pediatric hemato-oncology. And she has undertaken trainings in hematology and oncology at the Imperial College London, Hammersmith Hospital on a Commonwealth Fellowship. Welcome, Dr. Nyambura, over to you. You can start sharing your screen.
Thank you, Dr. Nafula.
Sorry, I cannot hear you. Can you hear her?
Yes, we can. I heard her when she said, thank you.
Thank you,
You
Dr.
can come
Yes.
on.
Can you hear
Yes,
me now?
Yes.
Okay, I'll talk a little louder then. So I think we can start. Okay, we'll be discussing the judicious use of non-steroidal anti-inflammatory drugs. Our main question is, we already know that the NSAIDs are used as anti-inflammatories, but over and over again, the question has come about the question of it being used in pain and fever has come over and over again. And our NSAIDs indicated in pediatric pain and fever. What about the side effects? That's what we'll try and deal with this afternoon. Okay, inflammation is a complex response to cell injury that primarily occurs in vascularized connective tissue and involves the immune system. Mediators of inflammation function to eliminate the cause of injury and clear away debris in preparation for cell repair. Unfortunately, the process of inflammation causes pain and tissue damage. Non-steroidal anti-inflammatory drugs are often used to control this process. We'll start off with the inflammatory cascade. The main thing is to show the relationship between the inflammatory cascade, fever, and pain, and then deal with the question of whether NSAIDs are indicated in pediatric pain and fever. In the inflammatory cascade, we start off with cell disruption, maybe through a puncture or through any injury. And this leads to the activation of the immune response at the site of injury. This will either lead to the release of histamine from mast cells at the injury site, or the disrupted endothelial cells themselves will release pro-inflammatory cytokines and chemokines, or the disrupted endothelial cells will release leukocytes, and this will be a leukocytosis inducing factor. As a result of the release of histamine, we end up with increased vessel permeability and vasodilatation with blood flow, increased blood flow to the injured site. And this will eventually lead to extravasation of immune cells and mediators and complement proteins and platelets. Eventually, this will lead to some of the cardinal signs of the inflammatory response. There will also be chemotaxis, an increase in the circulating white blood cells that eventually lead to the cardinal signs of the inflammatory response that include the redness, the heat, and therefore eventually can also lead to fever, pain, and swelling. Now, in the activation of the inflammatory cascade, in the inflammation of the inflammatory cascades, we are trying to understand the interrelationship between inflammation, pain, and fever. Through the action of phospholipase, arachidonic acid is synthesized. And this arachidonic acid, either through the cyclooxygenase or through lipooxygenase, through the lipooxygenase, you can see there will be chemotaxis, the leukotrienes, the leukotrienes will be produced, and there will be vasoconstriction, bronchospasm will be increased, and there will also be increased permeability. This eventually leads to vasodilatation and inhibit neutrophil chemotaxis, and it stimulates monocyte adhesion. On the cyclooxygenase arm, we can see that we'll eventually get an increase in prostaglandins D, E, and prostaglandin F. There'll also be vasodilatation and vasoconstriction. Through prostaglandin E2, we will have stimulation of the peripheral nociceptive endings, and somehow or other pain will be generated. So from the activation of the inflammatory cascade through prostaglandins E2, there will be an increase in pain, the peripheral nociceptive type of pain. Now, where do the COX-1 and COX-2 inhibitors come in? They inhibit cyclooxygenase. So, an examples of those drugs that do that, I'll just mention the common ones is diclofenac, aspirin, ibuprofen, and indomethacin. So this is the point at which they work, so that eventually the prostaglandin synthesis is inhibited. What are the mechanisms of pain? Pain can either be nociceptive or neuropathic. There's also the mixed nociceptive and neuropathic pain. The nociceptive pain that is due to tissue damage can either be somatic or visceral. The visceral pain is poorly localized. It's a diffuse pain and there's a deep sensation. The somatic pain, on the other hand, can either be deep or superficial. The deep is less well localized. The superficial is well localized. It's sharp, it's short in duration. In the neuropathic pain that is as a result of nerve damage, it's usually burning, shooting, gnawing, aching, or lancinating. It can either be via the central nervous system or the peripheral nervous system. Examples of the kind of pain that you get via the peripheral nervous system are the post-hepatic neuralgia, neuroma, and neuropathy. As far as the central nervous system is concerned, it can either be sympathetic or differentiation. And in the differentiation, there's a loss of sensory input. And these are the kind of pains that one describes as phantom limb, post-stroke, and spinal injury. In the sympathetic, you could have complex regional pain syndromes. Okay, the fever pathway. The originator of this may be infection, injury, or trauma. This will lead to the release of cytokines into the circulation. And you can see we are back to the synthesis of arachidonic acid with eventual synthesis of prostaglandins E2. And what do the prostaglandins E2 do? Prostaglandins E2, it inhibits the warm sensitive neurons. This leads to heat loss thermal effectors. At the same time, they activate the cold sensitive neurons, and this leads to heat gain and eventually enhancement of host defenses. Now, COX inhibition between arachidonic acid, and if there is a inhibition by COX, this is where COX works. So if we inhibit COX, then we will not get to heat loss thermal effectors, and instead we'll end up, the fever will be dealt with, because as a result of that, we'll have no inhibition of the warm sensitive neurons. So fever will be dealt with if we inhibit COX. And we can see where the COX-1 and COX-2 inhibitors come in. Again, the common ones we use in pediatrics in Kenya, diclofenac, aspirin, brufen, and indomethacin. With this COX inhibited, eventually fever is dealt with. Now, cyclooxygenase itself, what is the role and regulation of cyclooxygenase during inflammation? In other words, what's the protective physiologic role of cyclooxygenase? In the physiologic role of cyclooxygenase, we can see that there's a protective role as far as the stomach, the intestine, the kidney, and the platelets. There is a protective role. This is the physiologic function of cyclooxygenase. And then, so you can see arachidonic acid, when it's not inhibited, as far as COX-1 is concerned, the prostaglandins E2 have a positive role. All this we are discussing to show the side effects when the COX inhibition is in place, when we are using this medication. The protective role of COX-1 in the gastric system, there's gastric protection with increased mucus secretion bicarbonate and increased mucosal blood flow. This prostaglandin E2 is playing a protective role in the GIT. When we use COX inhibition, it takes away this protective role. As far as the kidney is concerned, prostaglandin E2 and prostaglandin I2 are working on afferent arteriolar vasodilatation and increased sodium and water retention. And in the cardiovascular system, the protective role is vasodilatation, inhibition of platelet aggregation, and also, as far as COX-1 and thromboxane are concerned, platelet aggregation and vasoconstriction. We look at some selective COX-2 inhibitors. The selective COX-2 inhibitors were developed in an attempt to inhibit prostaglandin synthesis by the COX-2 isoenzyme induced at sites of inflammation without affecting the action of constitutively active, the housekeeping COX-1 isoenzymes found in the GI tract, the kidneys, and the platelets. And the COX-2 inhibitors have analgesic, antipyretic, and anti-inflammatory effects similar to those of non-selective NSAIDs. But in contrast, they do not offer the cardioprotective effects of the traditional non-selective NSAIDs, and unfortunately, they also cause renal toxicities. So the COX-2 inhibitors, I know in pediatrics, we may not be using many of them, but they may be used in inflammation. They're the primary COX-2 inhibition with little action on COX-1, and we've listed some examples of some. And then they are the ones with preferential COX-2 and partial COX-1 inhibition, drugs such as nimesulide. Then there are the non-selective COX inhibitors. The non-selective COX inhibitors, they block the production of both the physiologic and the inflammatory prostaglandins. And they include drugs such as aspirin, diclofenac, ibuprofen, ketorolac, and ketoprofen, amongst others. And they either have the full COX-1 and COX-2 inhibition or weak COX-1 and COX-2 inhibition. Okay, some illustrations of some COX inhibitors and their use in pediatrics. I have chosen just a few of them, the ones that are commonly used as anti-inflammatories in our environment in pediatrics, and also as analgesics. I have a bias for sickle cell disease, and in the guidelines for management of sickle cell disease pain crisis, these are the drugs that are usually used, ibuprofen and diclofenac, as far as the non-steroidal anti-inflammatory drugs are concerned. Now, for aspirin, there is the analgesic antipyretic dose, and then there's the anti-inflammatory dose, and then Kawasaki disease dose, which is the antiplatelet dose. For the analgesic antipyretic dose, it is 10 to 15 milligrams per kilogram per dose. It can be given 4 to 6 hourly, and there's a maximum dose that we should not go over beyond. The anti-inflammatory dose, you can see, is at least 4 to 6 times the anti-analgesic antipyretic dose. The Kawasaki dose in Kawasaki disease is pretty high, and it is used until it's used during the febrile phase, and thereafter it is decreased to the lower dose of 3 to 5 milligrams per kg per 24 hours. And in Kawasaki disease, we continue the aspirin for at least 8 weeks or until both platelet counts and ESR are normal. For the ibuprofen, the analgesic antipyretic dose is given at 5 to 10 milligrams per kg per dose, 6 hourly. For JRA, you can see the dose is at least 3 to 5 times higher. And then there is ibuprofen is also used for closure of ductus arteriosus. And we can see the doses of the various gestations and the various ages. Aspirin is contraindicated in children who are less than 16 years old for treatment of varicella or flu-like symptoms because of the risk of Ray's syndrome. It's also contraindicated in cases of renal failure. Ibuprofen is contraindicated in hepatorenal damage, hypertension, edema, retention of liquids, gastrointestinal ulceration, or if there's any bleeding. The contraindications of ibuprofen are the same as the contraindications of diclofenac. Now for the diclofenac, we can see that the antipyretic dose is 0.5 milligrams per kilogram per dose TDS, but the analgesic dose is double that of the antipyretic dose. So when we are treating sickles for pain, we can't use the antipyretic dose. We use double dose, 1 milligram per kg per dose TDS. For the antipyretic, we can stick to 0.5 milligrams per kg per dose TDS. However, the maximum daily dose in children is 3 milligrams per kg per day. And then we've also written, we're also discussing the dosages of other pediatric dosages and the routes of other COX inhibitors. I'd like to mention ketorolac because it is one of the drugs that is being used when sicklers come into casualty in severe pain. For children, it's given at, if you are giving it IM or IV, that's ketorolac, it's 0.5 milligrams per kilogram per dose. That would be the start dose. Then after that, it can be continued 8 hourly. It can be continued 8 hourly. For 2 to 16 years, again, IV would be 0.5 milligrams per kilogram, but the IM dose would be double, 1 milligram per kg per dose. That's the start dose, and those doses can be continued 6 to 8 hourly. And in the mechanisms, as we've already discussed this, the mechanisms of action of the non-selective, of the non-selective inhibitors of COX, that they reduce the formation of pro-inflammatory and nociceptive prostaglandins. It also inhibits synthesis of prostacyclin and thromboxane, and it then regulates the lipooxygenase pathway. We'd already discussed that. And this is the point at which COX-1 and COX-2 inhibitors come in. The ones in use in our facility, diclofenac, aspirin, ibuprofen, and indomethacin. Just taking one of the common NSAIDs that we use is that there are other mechanisms of action. I just took diclofenac as an example because diclofenac downregulates the function of sensitized peripheral pain receptors by stimulating the L-arginine pathway. It is a nitrous oxide-induced increase in cGMP that facilitates opening of various ion channels, and it has been shown that cyclic GMP analogs induces peripheral anti-nociception, activating the ATP-sensitive potassium channels. So you can see its use as far as pain is concerned, the central mechanism. And then in the activation of the inflammatory cascade, the glandin E2 again can lead to peripheral nociceptor ending stimulation, ending in fever. And therefore, if the cyclooxygenase is inhibited, then that will be one way to manage fever. So are NSAIDs indicated in fever? Yes, they are. Are they indicated in pain? Yes, they are. And of course, we all know they are indicated in inflammation. So NSAIDs inhibit COX activity, interrupting the formation of thromboxane, prostacyclin, and the prostaglandins from arachidonic acid. These are some other mechanisms of action through the synaptic nociceptive transmission in the spinal cord. This involves NMDA receptors. And what diclofenac does is it attenuates NMDA receptor-mediated hyperalgesia via the L-arginate pathway. Diclofenac is a selective and competitive inhibitor of NMDA and increases the concentrations of kynuretic acid, which is an NMDA receptor antagonist associated with anti-nociceptive effects, and therefore has its effect on pain. So are NSAIDs indicated in pediatric pain and fever? We've gone through that, but the question is the side effects, because people have been worried about the side effects of NSAIDs. Okay, this was a study that was done on analgesic dose effect. It was comparing diclofenac potassium, paracetamol, and placebo. And it was found that diclofenac potassium, it was being done in adults, 12.5 milligrams and 25 milligrams, and paracetamol, 1,000 milligrams, induced statistically significantly better pain relief than placebo. And when it came to pain, the higher dose of diclofenac potassium was used. But when it comes to fever, you can use the lower doses. Only the two higher doses of diclofenac potassium, 12.5 and 25 milligrams, and paracetamol, 1,000 milligrams, can be considered effective analgesics. So when it comes to pain control, we need higher doses of the drug. And for the antipyretic effect, single doses of diclofenac potassium at lower doses of 6.25 and then higher doses of 12.5 and 25 milligrams, and paracetamol 1,000 milligrams, they consistently lowered oral temperature and the temperature profiles over time. This was in, so the important thing is to use the lowest effective single dose that would do this. So when it comes to temperature, we can use the lower dose. So we need low doses of the drug to control fever. Okay, what about use in the management of pain in sickle cell disease? The non-steroidal anti-inflammatory drugs are effective in relieving the inflammatory component of infarctive bone pains. NSAIDs can be added to the analgesia regimen for management of acute pain if there are no contraindications such as peptic ulcers, renal impairment, or cardiovascular disease. One complication of sickle cell disease that we need to be aware of is nephropathy, and it is characterized by proteinuria ranging from microalbuminuria to massive excretion. Therefore, when using NSAIDs in sickle cell disease in the control of pain, the treatment with these agents should be stopped after a week at the most. We prefer that you use a maximum of 5 days of NSAIDs in the management of pain in sickle cell disease. And use of NSAIDs for management of chronic pain in sickle cell disease is highly discouraged. But for the acute pain, we can use it. And at the dose, as far as children are concerned, if you're using ibuprofen, it would be at the dose of 10 milligrams per kg per dose TDS. If you're using diclofenac, at the dose for pain is the higher dose of 1 milligram per kg per dose TDS. And a study on the diclofenac or acetaminophen for paracetamol in pediatric tonsillectomy patients. And the conclusion of this study, it indicated that diclofenac was no more effective than high-dose acetaminophen for analgesia, but it resulted in a lower incidence of nausea and vomiting in patients following tonsillectomy. And then there was a study that was comparing paracetamol, brufen, and diclofenac potassium for pain relief following dental extractions and deep cavity preparations. And there were no significant decreases in mean pain for diclofenac potassium group compared to the paracetamol and ibuprofen groups at 4 hours. Changes in distress scores from the preoperative score to the postoperative score were made using the paired T test. However, there were significant decreases in distress scores between the preoperative and the postoperative scores. So the drugs seem to have done well, but they are at the appropriate dosages. And then there was a study comparison of paracetamol, ibuprofen, and diclofenac potassium for pain relief following dental extractions and deep cavity preparations. In that study, which is the one we've gone through, diclofenac potassium was more effective than paracetamol or ibuprofen for reducing post-operative pain associated with tooth extraction and deep cavity preparation. And what are the pharmacokinetics of NSAIDs? When orally administered, NSAID is absorbed rapidly and binds to albumin in the plasma, and the drug concentrates in synovial fluids, where it renders its targeted action as a non-steroidal anti-inflammatory drug for relief of musculoskeletal inflammation and ailments. Rectal administration of NSAIDs in our environment, what we use a lot is diclofenac. The rectal one has a higher bioavailability than the enteric coated tablets and an earlier maximum concentration. Again, the dosage of diclofenac is from 1 to 3 milligrams per kg daily in 2 to 3 divided doses. So are NSAIDs indicated in pediatric pain and fever? What about the side effects? We look at some side effects. Okay, these will help us see the side effects of non-steroidal anti-inflammatory drugs. And as far as COX protection at the GI mucosal level, if we have inhibition, then the prostaglandin E2, the gastric protection is lacking, so that there is no increased mucus secretion bicarbonate and mucosal blood flow, so that COX-1 inhibition will ultimately lead to peptic ulcers and GIB bleeding as a side effect. As far as the kidneys are concerned, COX inhibition will lead to a decrease in water and sodium retention, hypertension, and hemodynamic AKI. As far as the cardiovascular effects of COX inhibition, these are some of the side effects that occur. It may lead to stroke because of its effect on platelets, and also myocardial infarction, both because of the vascular and the platelet effect of COX being inhibited. So the side effects of the non-steroidal anti-inflammatory drugs, all non-steroidal anti-inflammatory drugs, especially more selective COX-2 inhibitors, carry an increased risk of myocardial infarction, heart failure, stroke, and death. As far as the gastrointestinal system is concerned, overall increased risk of acid-mediated damage to gastric epithelial cells, decreased ability to reproliferate the damaged areas, and GI injury ranging from mild erosion to frank ulceration, visible through endoscopy. All these are some of the side effects of NSAIDs. As far as the kidney is concerned, extended NSAID use also correlates with the development of renal complications. Ideally, we should, as far as pain is concerned and fever, no more than 5 days. Decreased prostaglandin synthesis has links with decreased renal perfusion and the development of acute kidney injury. The risk increases in patients with prior history of kidney damage and reduced perfusion pressure. So we should be especially careful when we are using them in patients like with sickle cell disease or other kidney-associated risk profiles. And then there are the hepatic side effects. NSAIDs can cause drug-induced hepatic damage and increases in liver transaminase levels. These events are usually transient and reversible. There are hematologic risks. There's an increased risk of bleeding. This has correlations with NSAID use due to the effects of inhibiting platelet aggregation and adhesion via COX-1 inhibition. Side effects of NSAIDs will include anaphylaxis. However, this is uncommon, and dermatological complications, mild to moderate skin irritation after use of the topical formulation. So NSAIDs should be administered at the lowest effective dose to achieve clinical goals to limit the risk of adverse reactions and toxicity. So in summary, NSAIDs are an effective management of pain and fever in children. But however, we should note that there are gastrointestinal, renal, and cardiovascular side effects. NSAIDs have to be used judiciously to prevent its associated complications. Thank you.
Thank you for that wonderful presentation. Please feel free to type your questions in the Q&A, but we'll go straight to the Q&A session, and there are lots of questions coming in. The first question, there's a participant who wants to know, do we have patients who lack cyclooxygenase enzyme? And so the drug using this pathway won't work?
I wouldn't know that. That's not my forte.
No problem. Now the issues, I'm not sure either.
Yeah.
I think that is something we could probably research on. So there's many questions about diclofenac, the use of diclofenac in children. Is the diclofenac suppository safe? Is it okay for children? And there's also a question about IV diclofenac. Is it safe for use?
Okay, the suppository, as we've gone through, is effective and it is safe for children. But when it comes to pain, when it comes to fever, the dose should be half that of analgesia, of pain and inflammation. So yes, it is safe.
Yes, then what about combined formulations, like the combinations that have paracetamol and NSAIDs? Are they effective for management of pain and fever?
They are effective, but sometimes the difficulty is in the combinations, because they have fixed, they don't give you room to adjust dosages of the NSAID downwards or upwards, depending on whether you're dealing with fever or whether you're dealing with pain and inflammation that need a higher dosage. So I think I usually prefer to use them separately so that I'm able to adjust my paracetamol and NSAID doses appropriately. Yeah.
Now, the issue of diclofenac and safety, there are some safety issues that were raised with especially cardiac patients, and some participants would like you to comment about that. Is diclofenac still safe for use in our patients?
I think I would, those are some of the precautions that one would take. What would you be using it for? For example, if you're using it for fever, then I'd rather you didn't use it. I'd rather that you avoided it, depending on the degree of the cardiovascular, because there are other drugs that can be used for fever under that setting. Even in the case of bleeding, a coagulopathy, or in the case of renal. Yes, if you are just controlling analgesia or you're controlling fever, there are other drugs you could use in that setting. Or if you must use them, then you use them at appropriate dosages and for a very short time.
Okay, there's an interesting thought here that someone has noted there is minimal difference between using NSAIDs and placebo on the on fever. So the question is on the issue of fever, is it, would you choose not to reduce fever at all if fever is one of the defenses and bringing down the fever will not prevent seizures? Should we let the child be in fever instead of using an NSAID?
If you're not comfortable using the NSAID, a neurologist should tell us. But if the objective is to bring down the fever, then as far as fever is concerned, the NSAID dose would be half that for pain and inflammation. But the other thing, it's always very important to find out why you have the fever. You wouldn't just be dealing with a fever, you'd be treating the cause of the fever. Because however hard you work with whatever antipyretic you use, if you're not dealing with the cause of the fever, then you wouldn't be doing much.
Yes. There's a question here for palliative care. I think I could respond to that. Someone wants to know about long-term use of NSAIDs in patients who are receiving palliative care, especially those with end-stage renal disease and comorbidities like diabetes, peripheral neuropathy. So the rules about using NSAIDs is just as Dr. Nyambura has presented. We look at the risk versus benefit. Now, in patients with end-stage renal disease, NSAIDs are not safe because they tend to worsen their kidney function. So we therefore try to avoid them as much as possible, and we use opioids instead. And now it depends on the degree of pain. If it is mild to moderate pain we use paracetamol, moderate pain we use weak opioids, and severe pain we then prefer to use opioids because of the kidney issues that will be worsened by the NSAIDs. Dr. Nyambura, there's a question about stroke. How does NSAIDs cause stroke by platelet aggregation and at the same time bleeding tendencies?
Okay, it's because of the role of platelets. Yes, by increasing platelet aggregation. Increased platelet aggregation will lead to thrombosis, and that will lead to vessel occlusion, and that could lead to stroke. Yes. Then, yes.
I think that's, yes, understood, but you could elaborate more because someone is also asking in the event of thrombocytopenia.
Yes.
And your patient has fever or they have thrombocytopenia without bleeding or with bleeding, would you still use NSAIDs in those circumstances?
In those circumstances, I usually try and use other medication. There's paracetamol. Yes. And usually if I deal with the cause of that fever and I use paracetamol, I'll be okay.
Yes.
Yes.
Now, patients with chronic pain in sickle cell, what would be the best way to manage their pain? Because these are patients that present with the painful crisis every now and then.
Dr. You could take that one. It is certainly not diclofenac. It is what you elaborated just now.
Yes. Yeah. So
paracetamol, opiates. Maybe you could go through that again.
Yeah. So of course, when a patient presents in the painful crisis, then we want to handle the crisis and the trigger of the crisis, and we will manage depending on the severity of the pain. Most of the time they'll present with severe pain, so we start off with opioids as we taper them off and eventually end up with paracetamol, or when the patient is pain-free, we stop the medications. So I think the important thing with patients with the sickle cell disease is to try and see how we can avoid the triggers of the crisis. And when they present in crisis, we want to manage the pain well according to the pain management principles, which starts by assessing the pain and then managing according to the World Health Organization ladder. And for chronic pain, we want to keep them off opioids as much as possible, because this is a category of patients who sometimes end up misusing opioids because of having recurrent pain. But it's just, yes, what we are saying, where there's contraindication, please avoid NSAIDs, use opioids and paracetamol. And in children with osteoarthritis, there's someone asking pain control for osteoarthritis and pain control for osteomyelitis, bone pain. Do we still use indomethacin for children, and at what dose for osteomyelitis?
Do you have a rheumatic on board?
I am not sure if there's any.
Yes.
I'm not sure.
I know that I know that the ibuprofens, COX-1 and various COX-1 and COX-2 inhibitors are used. But in that case, we are dealing with inflammation. And if we deal with the inflammation, we will deal with the pain. But it does mean that dosages for inflammation and analgesia are usually the same. It's the dosages for fever that are lower. Yes, I don't usually have to use indomethacin, because by then I refer.
Yes. So now our final question is about orthopedics, just about osteoarthritis, that someone has noted an orthopedic surgeon giving 2 NSAIDs for severe back pain, one selective and the other an unselective COX inhibitor. Is this good practice? Should it be discouraged because of the side effects of NSAIDs?
Doctor,
yes.
Have you ever used 2?
No. I've never used 2 because their mechanism of action is the same. Yes. So we probably want to choose the factors that we consider when choosing, because their side effects are also almost similar, whether they are selective or non-selective. But we look at issues of how is the dosing, what are the comorbidities of the patient, what is the affordability. I have never prescribed 2 NSAIDs myself.
I also haven't.
I think it is not practice we want to encourage. Yes. So I think we could end the session there. Thank you so much for attending today's webinar. Yes. Thank you so much, Dr. Nyambura, for the wonderful presentation and for accepting to do this webinar for us. Those who are concerned about CPD points, please send your emails to knhresearch@gmail.com, and the recording for this webinar will be available on our website just for you to go through. Dr. Karingo, do you have any announcements before we end the session?
Actually, we have a 10-minute presentation by Novartis, who have graciously sponsored this session. So we'll give them this opportunity to just do a short presentation on their product, and then we wrap up.
All right, thank you.
Thank you so much, Dr. Nafula, for a very elaborate. You can see my screen from your end.
You can put it in slideshow. Yeah. We can see it.
Yeah, thank you so much, Dr. Nafula. Okay. Thank you so much, Dr. Nafula, for wonderful moderation of this session. And once again, very grateful for Dr. Nyambura Kariuki for a very good presentation on judicious use of NSAID. And as Novartis, we advocate for this as much as we are the original makers of diclofenac. So my name is Daniel Gachushe, first line manager from Novartis, the neuroscience franchise. I'll be looking at just in a few minutes, fever, inflammation, and pain, and its relationship, and it has been dealt very nicely by Dr. Nyambura Kariuki. So I wouldn't want to go into so much details, and also look at what is Novartis offering on fever, inflammation, and pain. And of course, we'll conclude. I want to believe that all of us from this session you have seen the pathway as well elaborated by Dr. Nebura Kariuki, and how the two pathways, or the three pathways, have some common chemomediators. And prostaglandin involvement in all these pathways was well put, and also the role of COX inhibition. And as Novartis, we say that when you're dealing with inflammation and fever, and of course pain, then we have one bullet to help you with that in your patients. But this does not mean that you can use NSAIDs, for example, for long-term use. And that is why we are very comfortable to have such a conversation, because we know the use of NSAIDs has flipped on the other side, making NSAIDs again problematic to the HCPs and even the patients. And that is why we said it is very important for us to be in this conversation together. So it has been a concern to many doctors and even patients on fever, inflammation, and pain. And because of that, the management of the three conditions, fever, inflammation, and pain, needs to be optimized so that the maximum benefit of this, of the products can be felt by the patients, and by so doing, even by the healthcare providers. And as Novartis, being the original makers of diclofenac, we offer you products that have been there, that is Cataflam and Votarin, over 35 years. You'll agree with me that for a product to be here for over 35 years and still being used majorly to manage fever, pain, and inflammation, it means there is something that we did right as Novartis to come up with a product, because many things that were there 35 years ago, 40 years ago, they are no longer there. But for your patients, we have Cataflam, we have Votarin tablets, and even Votarin suppository to help you manage your patients. So for the Cataflam family, we have the Cataflam 50 milligram for adults, and also Cataflam 25 milligram for preteens who are below 40 years. And this one you give a tablet 3 times a day. For your pediatric population, we have the Cataflam drops and the Cataflam suspension. And I want to thank all of you for using these patients and using these products and making them available to your patients. And of course, we have the Votarin, the tablets, and the Votarin suppositories, the 50 milligram, the 100 milligram, the 25 milligram for pediatric, and 12.5 milligram. For today, because of the interest of time, I'll only narrow down to the pediatric formulation. In our subsequent interactions, we can go through the adult formulation. And probably you may ask yourself, why should you use Cataflam suspension or even the Cataflam drops to your patients, particularly when you're dealing with fever management? Cataflam suspension has shown a pronounced antipyretic effect, particularly in a study that was carried on patients that were suffering pharyngotonsillitis. These were about 82 patients, and the study was a double-blind study that was conducted for 5 days, looking at the efficacy of oral diclofenac potassium in combination with an antibiotic, and for this case was amoxicillin. And the patients were between age 1 to 8 years, and they were suffering from acute bacterial pharyngotonsillitis with a temperature between 38.5 and 40%. And 40 degrees, sorry. And as you can see from this graph, you can see the patient started with a temperature of an average of 39. And within a very few minutes, the temperature was able to come down. Showing that Cataflam suspension with a combination with an antibiotic offers fast onset of action, dropping fevers below 38.5% as compared to the placebo that was not able to offer that. So this offered a speed in fever reduction. On the same study, before we go to the part of inflammation and pain, another study was compared the 2 NSAIDs that majorly used in fever reduction, and that is ibuprofen and diclofenac. And this was a comparative national multicenter randomized double-blind trial that was conducted to about 300 patients aged 1 to 6 years. And you can see the rectal temperatures are about 38.5% to around 39.5%. And you can see clearly from this study, cataphragm suspension was able to significantly lower the antipyretic effects over 20 minutes than ibuprofen. Ibuprofen offered about 0.3, and diclofenac potassium, which is our cataphragm suspension for this case, dropped with 0.6. So clearly you can see if you need to use an NSAID and you have two that you need to consider in terms of the drop of the antipyretic effect, then when you go for cataphragm suspension, you get a better outcome. Looking at anti-inflammatory on the same study of about 82 patients who are suffering from Farigu's tonsillitis, you can see from this graph the percentage of patients that had the symptoms of inflammation reduced. Cataphragm suspension had a significant anti-inflammatory and anti-exudative effect within 6 hours. Again, comparing with placebo plus an antibiotic. So clearly you can see, which is definitely or obviously known by NSAIDs, that they are strong in anti-inflammation. Then you can see that when you're looking at a strong anti-inflammatory for your children or even adults, when you're dealing with cataphragm tablets, then the product to use is cataphragm. What about the pain relief, especially when you're dealing with patients with moderate to severe pain? Again, you can see cataphragm suspension was able to reduce pain within 30 minutes. Going back to the study of the 82 patients aged 1 to 8 years, again, you can see reduction of pain, which was measured through pain assessment, the visual analog scale. From close to 10, the pain was able to drop, or what you can say 100 was able to drop to almost 0 within 30 minutes, indicating that the speed that cataphragm is able to offer in pain management. So therefore, when you're looking at your patients, whether they are having fever or they're having inflammation or pain, or all of them together, then with cataphragm suspension or cataphragm formulation, then you don't need to look further. Then finally, sometimes when you have a strong NSAIDs, you wonder about tolerability and safety for your children. And I want to say sometimes people shy away from cataphragm because of its strong efficacy in pain, inflammation, and fever, because they are fearing about the safety and tolerability. But what we can say as Novartis is, if you use it for the right patients, the lowest effective dose and for the least period possible, then you are not, you should not be worried about the tolerability and safety. And this is confirmed by a study that was a multi-center one that was carried out with about over 5,000 children and was assessed by over 1,700 physicians, looking at the safety and tolerability of cataphragm suspension. And from these investigators, 96.4% rated cataphragm suspension as excellent or good when it comes to tolerability and safety. And we further carried out a study comparing ibuprofen, again, and diclofenac being the major NSAIDs that are used particularly in children. And as you can see from this study, which was also a multi-center randomized double dummy study looking at the two NSAIDs, you can see that percentage of patients that reported adverse events for cataphragm, which is diclofenac potassium, was 0.8% compared to ibuprofen, which was a high of 2.5%. So again, you can see when you're looking at safety, when you're looking at the drop on fever, when you're looking at a good anti-inflammatory and a good pain medication, then cataphragm is the drug to go for. Then as I conclude, dosage is very right, and we believe when you dose it right, you are able to achieve what you are looking for as a doctor. And again, also you are able to avoid the side effects that can come with use of NSAIDs. For cataphragm suspension or cataphragm, diclofenac is given as a range. So we always recommend that you go for the lowest effective dose of 0.25 ml. And 0.25 ml is equivalent to 0.5 milligram of diclofenac. And you can go all the way to 1 ml per kg, depending on the condition that you are treating, like Dr. Nyambura Kariuki mentioned. And you're aware that 0.25 is basically a quarter. So we are saying it's a quarter per kg. And a quarter per kg is you just take the kg of the baby and you divide by 4. And that is the example that is you can see on your screen. So if the baby is 20 kg, you divide by 4, that is 5 ml, and you give 5 ml TDS. Like we said, maximum 5 days. You can even go as low as 1 or 2 days, depending on whether the symptoms have been resolved. If you are dealing with an odd number like 23 kgs or 27 or 13 kgs, again, you round it off to the nearest 5 or to the nearest 10. You will still be within the lowest effective dose. So I believe with what we have been able to present to you this afternoon, as I summarize, that cataphragm is able to significantly offer you pain relief starting at 15 minutes, 1 hour for complete fever reduction, and 2 days for symptom relief. I want to believe that now we are more aware about where to use the NSAIDs and the dosage to give and the duration to give. And this conversation can continue at our hospitals, at our pharmacy centers, to ensure that we don't shy away from NSAIDs when it comes to fever reduction, when it comes to inflammation and also pain, because if you use them right, then definitely your patients will be able to benefit. So I want to believe that the next patient that you're going to come across, you're going to use our different formulation of diclofenac, which is whether it's cataphragm adult formulation, cataphragm pediatric formulation, or even Votarin, the tablets for adult, or even the Votarin suppositories that are available in your hospital. So I think that brings me to the end of my presentation. Dr. Nafula, if there is any question, I'll be happy to attempt to answer them. Thank you.
Thank you so much for that wonderful presentation. I'm not seeing any further questions in the chat for you. So I think it is safe to say that we can end there.
Thank you.
So they want contacts of the Novartis presenter.
I can give my number. Is 0721 395 134. 0721 395 134. I can also put it on the chat before 1 or 2 minutes.
Yes, please. Yeah, for 1 or 2 minutes before we end.
Sure.
Thank you. Someone is asking about the slides. You'll get the pre-recorded presentation from our website, the KNH official website. Thank you so much for your presentation, Daniel. Please share your contacts, then I will hand over to Dr. Agnes. We've come to the end.
Thank you so much.
Yes, thank you very much, everyone, for attending this session. We welcome you for future sessions. You'll be able to get our CPD points via our emails, the ones we used to register in, and for clinical officers, we'll send the names to the council. Thank you so much, everyone. Thank you, Dr. Nyambura Kariuki, for that wonderful presentation, for Dr. Nafula for guiding us through, and thank you, Daniel, for that Novartis presentation. Do have a lovely afternoon. I'm Dr. Karinga from Kenyatta National Hospital Medical Research. Thank you.
Thank you so much.